Thanks, Grant. It's a real honor to be here. I remember coming to these meetings when I was a resident and then a fellow, and then to be up here on the podium, I gotta say it's one of the most, one of the biggest highlights of my career, being here and being able to learn from all of you, and all of you that I respect a lot. So we'll talk today about the revising of the failed humerus and the case for tumor prosthesis. As Eric so eloquently stated, whenever we deal with humeral bone loss, it's always associated, or at least risk of associated, with instability. And that's because we lose the compressive force of the deltoid against the tuberosity if it's missing. And the deltoid can then act potentially as a distraction force against your construct. And this was appreciated earlier on, back in 2011, by Dr. Walsh, when he found that in patients with proximal humeral fractures and missing their tuberosities, the patients with dislocations also had no tuberosities. So when we think about proximal humeral bone loss, I think it's good to strategize and categorize the level of bone loss. So this categorization system, the McLendon classification, was in the setting of tumor, of course. And of course, there's type 1, 2, and 3 based on the extent of the bone loss. But Peter Chalmers reviewed proximal humeral bone loss and management of this, and found that there's another classification system called the Pharos grading system, which was better inter-observer correlation. So I like this classification system, and I wanted to point out that, again, there's 3 different grades, but in type 1, type 1C, meaning missing bone loss along the calcar, 1G, which is just missing the greater tuberosity. And then sequentially, type 2 is more like a epiphyseal, a metaphyseal bone loss, and then type 3, of course, is more distal to that, into the diaphysis, and then ending in type 3B, which compromises the deltoid tuberosity. So that's going to dictate our treatment. And of course, there are gray areas in between, and we can debate which is better, the APC or the megaprosthesis. Well, if just logically talking through this, I would favor an APC, of course, in a patient who's younger. Patients who have a type 1 bone loss, if it's just the tuberosity or just the calcar, and it's not very large, then you can argue you can do an APC, or you can kind of build that up with just placing the implant more deeply into the humerus and building that up with the inserts, or building up the tuberosity partially with some cement. The other benefit of the APC that Eric so beautifully showed was that you can include the rotator cuff attachments when you order your allograft. And you can use those rotator cuff, that tissue from the allograft, and sew that in to some remaining tissue, some pseudocapsule or remaining rotator cuff stump, and that can lend some stability to your construct. The downside of that is that it is time-consuming. Using a mitis on the back table, making the step cuts, measuring, remeasuring, recutting, and fine-tuning with a burr to get the maximum surface area between the allograft and the host. That's extremely time-consuming, and of course it's costly to order an allograft. And then long-term, when we look at the studies about the allografts and some cases that I'll show later, the grafts can resorb. And that can result in failure of your fixation. So let's talk about megaprosthesis, endoprosthesis. Well, that's maybe an easier decision to make if it's an older patient. You theoretically could have a faster surgical time because you're not futzing around on the back table with the allograft and remeasuring and recutting. Usually the megaprosthesis is used in bigger defects, so these are more complex cases, and you have a risk of instability because the deltoid tuberosity is lost and you lose some of that compressive effect of the deltoid. Of course, the implants are also costly, And the question is whether the implants, as we evolve and technology evolves, maybe these implants will be improved over time. And the unknown issue is what we saw in some of these shorter stems, is that when we're diaphyseal loading the implant, are we going to see short proximal stress shielding, and can that lead to eventual loosening of the implant over time? So this is Eric and Dr. Sanchez-Sotelo paper from the Mayo Clinic, and this is just showing that they had a very good union rate, and survivorship at 5 years was 96%, but there was a 20% reoperation rate. These are salvage cases, these are multiply operated shoulders, and it shows also that he used that compression grafting plate technique with a step cut that Eric showed, and the beauty of using the allograft is showing that proximal tissue, the rotator cuff, that you can incorporate into your repair. This is a slightly larger study by Dr. Frankel's group at 73 shoulders, and they also had a similar revision rate, so 20%, similar to the Mayo Clinic series. And the survivorship is good, but definitely not as good as primary or revision surgery for non-proximal humeral bone loss. And this is a combined study from the Mayo Group and the University of Florida, showing that overall they had a pretty reasonable incorporation rate. And so knowing all of this about the APCs, what about the megaprosthesis? Well, a lot of the studies on the megaprosthesis are very small. A lot of them include tumor cases, which are not typically what we deal with here. And so like the great white shark is the ultimate ocean predator, the megaprosthesis is the ultimate shoulder reconstruction procedure. Dangerous and maybe kind of fun to watch. So this is a minimum 2-year outcome. This is the Exactech group, but average follow-up was 3 years. And they found significant improvement in all the shoulder scores and range of motion. But on average, these patients are able to get up to only about 90 degrees of active forward elevation. And the complication rate hovers around 30%. And the most common complication is dislocation. This is the Mayo Clinic study looking at megaprosthesis for severe proximal humeral bone loss. I apologize, there's a typo. The average follow-up was 4 years, not 2 years. And this is specifically using the SRS megaprosthesis system, and 12 out of the 76 were tumor cases. But longer follow-up, bigger patient population than the previous study, and their complication rate was also pretty high, 42%. The most common complication, again, instability, periprosthetic fracture, distal to the implant, and infection. And the revision rate is 26%. So the risk factors for revision surgery were patients who had multiply operated on shoulders, and the reason why was because it may be that the compromised endosteal bone from the prior failed arthroplasty or tumor may affect on-growth long-term or cement interdigitation. So here are some exemplary cases. This is a patient that I saw back in 2019, an 80-year-old female with a painful hemiarthroplasty. You can see here the tuberosity has been lost because this was done for fracture. The implant is placed relatively high in the humerus. I removed the stem by creating an episiotomy. You can see the cement mantle is not very robust here, so luckily a longitudinal osteotomy was all that was required to remove this stem. And I used a cemented stem 5-6 years ago now with these cerclage wires. And at 1 year post-op, she was doing pretty well and happy with it. But 4 years later, follow out this 4 years later, she starts to develop humerally based pain. And you can see, if you look more closely, is that the cortex is starting to dent a little bit from the cerclage wires, and she's developing some humeral based loosening. So it wasn't just that their wires were painful and symptomatic, but it was actually the whole stem was loose when we got there intraoperatively. And we tried to press fit this stem, but we used this tumor prosthesis, and we were able to cement this in, and overall she's doing quite well at 1 year post-op. So this is a more complex patient that I saw many years ago, back in 2009, had a total shoulder placed for osteoarthritis. And you see that there's a decreased acromial-humeral distance consistent with rotator cuff dysfunction and glenoid component loosening. So back in 2010, I removed his total shoulder arthroplasty. I windowed the humerus and did an osteotomy. I did an allograft here. He did well for 10 years. 10 years later, he comes back, some humerally based pain. The allograft is starting to resorb, and then I eventually, he had a motor vehicle accident 3 years after that, and I eventually revised him to an endoprosthesis. So just to show you, and I will finish up here. So a gross metallosis and reconstruction with a tumor prosthesis, and overall doing well. Thank you.
Excellent.